headache is a very common encounters for doctors in clinical practice. Of course, in neurology practice, we have received a lot of referral of a primary headache to rule out secondary headache. So there are mainly two important questions that you have to ask yourself whenever you have a patient referred for headache. All right. So one, you have to differentiate whether this is a primary headache or whether or not this is a secondary headache. How can you differentiate? It's mainly based on a clinical history. All right. So most of the headache diagnoses are entirely from the patient history, and whenever you examine the patient, very rarely you will get to to have some neurological deficit, especially in primary headache. And another question, important question that you have to ask, whether or not is there any red flag signs. All right. So it is a very simple mnemonics that you can that can inform to you. Is actually SNOOP mnemonics. All right. One is systemic signs or disorders, one of the red flag signs, whether or not the patient has neurologic symptoms, whether or not this is the onset of headache is new, all right, and whether or not the onset in a thunderclap presentation that commonly you see in subarachnoid hemorrhage, or whether or not there's any clinical evidence of papillary edema for P, all right, and whether or not there's any pulsatile tinnitus in the history that you can get from the patient. So whenever you mainly in primary headache, is there any slide here? Yeah. Okay, all right. So this is basically approach to headaches. So as I mentioned to you, one important question you have to ask whether you have to differentiate whether this is primary or secondary headache, and is there any red flag sign? So if you can answer these two questions, then I think you can manage this case, effectively. So next slide. So mainly when you have to differentiate whether this is a primary headache or secondary headache. Okay. So primary headache are basically the commonest headache that you see in outpatient clinics. Like migraine, which is a unilateral throbbing headaches that are associated with nausea, vomiting. They can have prodromal symptoms, they can have aura. Some patients can have prodromal of confusion, so these are the things that you have to get from the history, So typically they are unilateral throbbing headache. It can be very severe, okay. In tension type headache, they are usually a band-like tightening over the forehead, and they tend to be boring type of headache, okay. So, and they're usually recurrent attack, okay. So and there's also another primary headache that you should not miss, which is a cluster headache. In clinical practice or in neurology practice, cluster headache is actually not very common in Malaysia. All right. So importantly about secondary headache is actually when you identify the red flag signs, okay, the SNOOP mnemonic, then you should be able to go through few differential diagnosis of secondary headache. Like I think in this case, like that we are discussing today is actually a young lady with new onset of headache. All right, and if you go through the character, it doesn't sound like migraine, and she has associated symptoms of vomiting. All right, so this is acute onset headache for 2 days with vomiting, and of course you would like to think whether this could be a secondary headache. And headache that occur just suddenly, always think about vascular event, all right? Because other different types of headache, like space occupying lesion, intracranial hypertension, as what I have listed here, tend to be chronic, like a chronic headache presentation, more than 2 weeks headache. Then you can think of a space occupying lesion, intracranial hypertension in patient with, have features of metabolic syndromes, and of course, patient with headache and have fever at the same time. Typically, you would think of brain or CNS infection. Okay, and of course, if they are having just headache, meningism, then meningitis. If they are having seizures, then think about encephalitis. And when you talk about approach of a headache in secondary type of headache, and if you identify this is likely to be a secondary headache, then imaging, a basic imaging, which is brain CT should be performed in patients with suspected secondary headache. Okay. If you are thinking about intracerebral hemorrhage, then a plain CT would be enough. But in certain conditions, you would need at least a contrast enhanced CT. You know, for example, in case of arteriovenous malformation, you need to have a contrast image as well, because it will show you serpiginous vessels, and in cases of sensitive sinus thrombosis, you would like to see filling defect in the contrast enhanced imaging.
Okay, so when do we actually need to refer to neurologist? Okay, yeah.
Well, I think a chronic headache or secondary headache or primary headache who actually disabling should be referred to neurologists. Okay, a migraine headache, for example, that has infrequent attack once a month or once in 2 months, can be treated as outpatient by general practitioner. But if they're having migraine with frequency of more than 4 times in a month, then they should be treated by neurologists, because they require prophylaxis for the treatment. And in this case, because this is an acute headache in young lady, of course you would think high in the list this could be a brain pathology. Then I think referral to neurologist is justified, so that we can one thing, of course, you can get early detailed imaging, and of course you would like to assess for any subtle neurological deficit.
Okay, so one of the investigations that Izrina mentioned just now is doing lumbar puncture. Okay, so when do we actually need to do lumbar puncture in this kind of scenario, and what is actually the cut-off limit? As we showed just now, her platelet counts were 80 at presentation. Yeah.
Right. Okay. Thank you, Prof. Rafi'a. I think in cases where you suspect that this could be a chronic CNS infection, then CSF analysis is very, very important, because differential diagnosis can be viral, can be fungal, or even in Malaysia, tuberculosis can present with chronic headache. Okay, so then CSF analysis would be important. In another condition other than infection that we always require patient to have a CSF analysis is idiopathic intracranial hypertension. But they tend to have a chronic headache. You would like to have the CSF analysis, one, to rule out with chronic CNS infection. The other thing is actually to look at the CSF pressure, because you need that for the diagnosis of idiopathic intracranial hypertension. In terms of CSF procedures or lumbar puncture, I think as long as the platelet is above 50, is quite safe, because lumbar puncture is not high volume, high risk procedure in terms of it involve large vessels So I think CSF analysis above 50 would be adequate and safe for the procedure.
Okay, thank you. So we have a few CT images here. Okay, so can you enlighten us on how to describe and interpret CT brain? Okay, some basic interpretation.
Okay, alright. I think for medical officers and the training physicians, I think what is required for you to is actually at least interpret a basic CT scan. So the common or basic CT scan that you get to see in emergency department or in the ward are mainly the axial cut of the CT scan. Okay, so what you can see here is a plain CT scan. We can start from the above cut is actually the base of the skull. Okay, so when you look at the first cut, I don't have the pointer here. The other side. the first cut. Yes. So that is the base of the skull. So for plain CT brain, you should be able to identify the posterior fossa structure here. You know, so maybe Izrina can show. You can interpret if you want, but the right and left cerebellum. Okay, so right and left cerebellum. So I think this is the basic cut, you know. So at least at base of the skull, you should be able to identify the posterior fossa structure. Okay, identify the cerebellum and the brainstem structure. Okay, so at this level, it's very difficult in plain CT brain to see the whole brainstem structures, because especially the medulla, because it's very much at the bottom. Okay, so at this cut, if you can see, there's a round structure in the middle in the posterior fossa structure, which is the pons. Okay, so if there's any bleeding, any obvious infarct, you should be able to see by looking at this cut. Okay, so the cut at the bottom on the right side, yeah. So this is slightly higher. So if you look at the middle part of the scan, it's actually slightly butterfly shape. So this is actually your midbrain. So when you go from the base of the skull, you see the pons, and you go slightly higher, you see the midbrain. Okay. So if there's any pathology here, you should be able to see. Alright. So and then when you go to the middle cuts, here is actually very important cuts where this is a basal ganglia. You can see a basal ganglia structure. You know, the thalamus, the head of caudate, okay, and also the ventricle. You can see this is a very normal looking ventricle, okay, and you can see the grey and white matter differentiation. So this is actually the basic important CT brain description that you should be able to describe. And the last cut is actually a centrum semi-ovale. Okay, so this will be the higher cut, you know, the higher parietal cut. So if there's any bleeding, any swelling, you should be able to see.
Okay, as you can see, the contrasted CT brain here, there is hyperdensity over the parietal region, the left parietal region at this juncture. So that was indicates, intracranial bleed at the left parietal region.
Okay. Alright. So is there any other changes that you can see here? Because whenever you see a bleeding over a high parietal region on the left side, right? So there's a bleeding on the left parietal region, and there's a hypodensity surrounding it, which is a perilesional edema. Okay, so in this young lady with a normal blood pressure, okay, so are you thinking of, typically you see hypertensive bleed, right? But I think the location is just not for hypertensive bleed. You see most of the time hypertensive bleed occurs at the basal ganglia structure, the thalamus, you know. So, but if you look at this scan, this is a contrasted scan. So, if you look at the sagittal, there's an anti-delta sign there. All right. So I think you can see it very clearly. So this gives you a clue. All right. Without a contrasted scan, you might not be able to differentiate what is the cause. Alright, so I think this scan is actually very clearly showing you that there's an anti-delta sign over there. So then you know that this patient's bleeding in the intraparenchyma is due to sagittal sinus thrombosis. In sagittal sinus thrombosis, usually it causes venous infarct. Venous infarct has higher risk of hemorrhagic transformation as compared to arterial infarct. That's why whenever you see bleeding in young lady, normotensive, always look for evidence of, you know, a filling defect in a contrasted scan.
Okay, yeah, basically because when patients admit through emergency department with the intracranial bleed, so of course patients are straight away usually admitted under neurosurgery. So I think it is important to differentiate whether this is a venous infarct okay, and whether it's like a hypertensive bleed, okay.
So, alright, I think you can, alright. So I just would like to show these changes of several venous thrombosis in plain and contrasted scan. So if you look at the first scan on the right, which is a plain scan, you see that there is no evidence of filling defect. What you see is just bright signal, in the sagittal sinuses, alright? So this is also one of the clue. You see the pointed arrow there. If you have a plain scan with a hyperdense area over the sagittal sinus, and on the middle scan it's actually at the transverse sinus. So this is actually indicating areas of thrombosis. Okay. Similarly, when you see a dense cord sign in NCA thrombosis, right? So it's very dense because the presence of thrombosis. So whenever you perform a contrast enhanced CT, there will be no flow of contrast. So that's why you see a filling defect at the sagittal sinus. All right. So if you look at this scan, these are all features of bleeding in sagittal sinus thrombosis. So you can see that it can be at the center, at the thalamus, which is because of the thrombosis of the internal venous vein, or at the straight sinus area. Okay, you can see it can occur at different parts. All right, so it's very difficult to differentiate without having a contrasted scan, or even sometimes we resort to having MRI. Then only we can differentiate whether this is due to thrombosis or not. So I think at the first encounter can be quite difficult. Some of the patients will go to neurosurgery before they actually refer to us.
Okay. So, Izrina, so what is the most likely cause of the intracranial bleed in this patient?
Alright. So this is a lady, young woman coming with acute headache associated with thrombocytopenia as well as hypoalbuminemia. So we have seen the CT, the contrasted CT brain, which showed sagittal sinus thrombosis, venous infarct associated with hemorrhagic transformation over the left parietal region. So I think the most likely diagnosis for this lady would be cerebral venous thrombosis associated, complicated with hemorrhagic transformation.
Okay, so at this point, we have a young woman presented with acute headache associated with vomiting. Investigation showed thrombocytopenia with hypoalbuminemia, and the CT brain showed sinus thrombosis. So what further investigations would you like to perform at this point?
So basically, in a young lady, the likelihood of autoimmune condition, the connective tissue disease, will be of a higher, likelihood for the underlying causes. So in view of the evidence of thrombocytopenia and also thrombosis, so I would need to consider to send for thrombophilia screening, thrombophilia tests, which include protein C, protein S, antithrombin activities, as well as the APLS antibodies, including anticardiolipin, lupus anticoagulant, and beta glycoprotein.
Okay, so Izrina mentioned about thrombophilia test and screening. Okay, so these are the investigations results of this patient. So we have here protein C, protein S activity, and also antiphospholipid antibody. As you can see here, the anticardiolipin IgG is elevated, it's positive, and also the anti-beta-2 glycoprotein 1. And this is also the lupus anticoagulant test. Okay, so I would like to call upon Prof. Nora Shikin from Department of Pathology to help us with the interpretation of these results.
Thank you very much, Medical Department, for inviting me. So let me share the thrombophilia screening test that we offer in our specialized hemostasis